Welcome. My name is Martin Hoenigl. I'm Associate Professor at the Division of Infectious Diseases and Global Public Health at the UCSD, and I will talk now about the run-in period as a complex trial design. So here you can see the run-in design. So basically what happens here is that after screening and consenting patients and before basically randomizing the patients, we have this placebo run-in period. Afterwards, after this run-in period, some patients, not all necessarily, get randomized into arm A and arm B. What is the reason for introducing such a run-in period? This gives us a chance to, for example, exclude patients where we know compliance could be unsatisfactory, patients that drop out of the study. So it's a way to really increase the power of our study. And basically, to summarize, a run-in period is a time period after inclusion but before randomization, and it's really used to exclude certain patients that we think would not be good for our trial, for our study, and would decrease potentially power because they might not be compliant, they might have a huge placebo effect, or they would drop out. So how does this function? Basically, all participants initially receive the same intervention. This doesn't have to be necessarily be placebo, as I showed before. This could also be an active treatment, or it could be no intervention at all. And during run-in periods, patients are then really excluded due to non-compliance with treatment or data collection, or response to placebo. That's another way for how to use run-in periods, or intolerance of the medication, device, or behavior. What are the advantages? The advantages is by excluding non-compliers, placebo responders, or intolerant participants, a run-in period may really increase an explanatory study's power, that is, change of detecting a potential treatment effect. So that way we can, if it's not easy for us basically to enroll a large number of patients into a study, that is something that we can implement into our study design to increase the power, to increase feasibility. So it has, of course, very reasonable advantages, but it doesn't only have advantages. There's also some very important disadvantages that come with the run-in period. So, of course, it will increase our power, but a run-in period may also affect external validity. And this is really the ability to generalize study findings to the population at large. So we may find something in our study, and we may have sufficient power to find something in our study. But at the same time, it's unclear how this translates to the real world, the external validity, and how our findings translate to a real population, where, of course, people responding to placebo or people intolerant to a certain intervention are not excluded. Then it could also affect internal validity. And this is really the degree to which the study accurately answers the question it was intended to answer. And that's, of course, also a big problem, because at the end we might not be able to answer our question when introducing this run-in period into our study design. I now want to introduce the first exercise. So the objective of this exercise is really that during watching the video, the lecture, I'll present two options for a run-in period design. And then I'll pause a bit and give you some time to really select one of the research questions that may be best answered with the respective complex trial design, here the run-in period. And after watching the lecture, and this is really something you can do later, I would also ask you to design the randomized clinical trial with the assigned complex design and the option choosing, including a flow diagram, to define the primary outcome, and to list for both options benefits and disadvantages of the respective complex trial design versus a standard parallel design. But this is please all done after watching this lecture. So let's jump into the first exercise. So here again I show you what a run-in period looks like. And we have here two options. Option 1 is the study question to examine whether a novel immunotherapy drug for recurrent PD-L1 positive metastatic non-small cell lung cancer is effective in prolonging survival versus chemotherapy. Option 2 is to evaluate the effectiveness of a structured 30-minute daily exercise program over 12 months plus individualized diet versus standard diet alone in reducing body weight in obese type 2 diabetic adults with a BMI above 30 below 50 years. So I give you a few moments to think about which of these two options would be more appropriate for a run-in period study design. And here, there's the solution of exercise 1. So basically, option 2 is the right answer. To evaluate the effectiveness of a structured 30-minute daily exercise program over 12 months, plus individualized diet versus standard diet alone in reducing body weight in obese type 2 diabetic adults below 50 years. You can imagine that compliance in such a study would be a problem. So here, maybe a run-in period would really kind of like help us to select people who are compliant to either the intervention or the standard of care. And people with non-compliance to diet could be excluded during the run-in period. Option 1 is not as good, obviously, because first of all, a run-in period sometimes delays the intervention with a new drug. So that's a problem, obviously, because if we have a new promising drug, we want to give this right away to such a patient where time really matters. And then there are also, of course, a ton of other confounders. But most important, you really want to start treatment right away and don't have a further delay. Also, compliance is not such a big an issue in patients with advanced lung cancer. Thank you.